Hello, my name is Nirav Raval. I'm the Thoracic Medical Director at Advent Health Transplant Institute. I'm here today going to speak about LVAD therapy and the current state of the art. Thank you to the organizers of the program and Craig Walker as well for allowing me to be a part of this offering. Well, we have a lot of challenges in advanced heart failure, and some things have changed over the years and some things haven't. Ventricular assist device therapy has really come to the forefront, and I wanted to make sure that everyone knew what was happening here in the current state and maybe some things that are happening down the line. Heart failure still has a pretty devastating public health consequence in the United States. You can see here that 5.7 million patients suffer from it in the United States from a prevalence standpoint. But from an incidence standpoint, this is actually going up. About 915,000 new patients are diagnosed with heart failure every year. And that's actually gone up, and it's in fact it's expected to increase to around 46% by 2020 this year, and I think we're on target for that. About 250,000 people die of heart failure every year, and this really hasn't changed really since the 1970s. So class 4 heart failure is very similar to very aggressive malignancies, in fact. So if you look at lung cancer or pancreatic cancer, it's very similar in its morbidity and mortality to heart failure. You can see the one-year mortality rates are similar across all three of those entities as well. So transplantation is really potentially the gold standard, but I mean, obviously the supply of donor hearts is limited. You can see there's about 25,000 patients that may, become a candidate for some sort of advanced therapy, LVAD or transplant, but only 3,000 individuals per year would be able to get a heart, and that's obviously only a fraction of what's needed. So as we see the number of transplants go up in the middle 2000s, we saw kind of a flat area of the curve, but now recently in 2012, let's say, we've had an increase in the amount of heart transplants that have occurred in the United States, but still, to the earlier point, it's only about 3,000 per year, and it's still a relatively small proportion of the people that actually need some sort of therapy for their advanced heart failure. So the key, I think, is to really, one, identify and understand the advanced heart failure patient. Who is that patient? What do they look like? So defining advanced heart failure becomes really complex. I mean, in the old days, we really looked at things like NYHA classification. Obviously, NYHA class 4 patients really were the most symptomatic. They have severe limitations. They have symptoms even at rest, shortness of rest at rest, or maybe even patients that are sort of housebound or even bedbound. But what's interesting is that the new classifications for INTERMACS, which is a registry for those individuals that are undergoing ventricular assist device implantation. If you look here, the 7 sort of INTERMACS categories really are spanning between NYHA class 3B and 4 heart failure. And you can see that it's an increasing way, worsening of symptoms. So 7 INTERMACS may be just sort of advanced heart failure in a NYHA class 3B way. And then as you get towards 1, you can see critical cardiogenic shock, and you can see the different gradations between 1 and 7. So, the fact is that we have a lot of treatments for this, and this is a bit of a busy slide, but the fact is on the surgical side, you may have things like an ICD or CRT, and even culminating with heart transplantation or ventricular assist device. Certainly there's medicines before you get to those types of things. You want to make sure that patients are on optimal medical therapy. And of course, lifestyle really underpins all of it. What's interesting is that the patients that come to us as advanced heart failure cardiologists really come to us at kind of later stages. So INTERMACS 3, 2, and 1. Very few actually come on a proportional basis between INTERMACS 4 through 7, which are patients that are a bit more stable and but still quite symptomatic as well. So how do we determine who these patients are and what are maybe referral criteria, right, for who these patients are and how should they come? We look at it in 2 different ways. One is a functional assessment. Usually we talk about patients that are unable to walk more than 1 block without significant shortness of breath. Patients that have been on maybe medications such as ACE inhibitors and beta blockers, but we're having to now pull that away. They're becoming intolerant or refractory to these agents, and you have to pull those away because of low blood pressures. More than one heart failure hospitalization, really, that impacts patients' mortality. Your Kaplan-Meier curve gets worse every time you have a hospitalization. So there's an actual cost from a mortality perspective for hospital admissions. CRT non-responders, and I think we do a pretty good job with this to try and optimize those devices, but once they're non-responders, I think that's something important to look at. And then obviously patients that take a tremendous amount of diuretics, you can see they're 1.5 milligrams per kilogram per day of a furosemide or similar, would be somebody that really needs probably advanced therapy evaluation. And on the lab front, low serum sodium, high BUNs, kind of modest creatinine elevations, nothing that you might send to a nephrologist, but the fact is that it might be that the person actually has low cardiac output, and this is why their BUN and creatinine are high. And of course, anemia, chronic disease with a hematocrit of less than 35, this would be also a reasonable thing to kind of add in. Not every one little thing is going to be the key, but really if you start looking at all these and you start seeing that there are multiple situations here, you might want to send these individuals towards an advanced heart failure cardiologist. Well, the earlier you send, the better off the patients are really going to be from a perspective of better survival and even a reduction in hospital lengths of stay. So, for example, if you are sent at an earlier stage like Intermax 4, those individuals literally will have a 1.9 times higher survival rate at 3 years and a significant decrease in hospital length of stay. If you're in critical cardiogenic shock, the outcomes are going to be certainly checkered, and the cost per case goes up, predominantly length of stay driving that. Of course, there are other more morbidity related things that would increase the cost of the hospital stays as well. So VADs really have been really coming into their own since really 2006. We had the HeartMate 2, really excellent experience with it worldwide, and now the HeartMate 3, for example, using one VAD as an example. And these are really tried and true pumps, and that have really been shown to be helpful. And we'll talk about other VAD platforms as well. So this is not anything new. Really, this has been going on since the late 1980s, and we've just gotten a lot smaller and a lot more durable in terms of the actual pump itself. And currently, really, what we see is better blood handling, and this is important because you have wide open blood flow pathways, frictionless design with completely magnetically levitated systems, and then that really leads to minimal pump thrombosis, low hemolysis, and worse, better shear characteristics of the blood as it flows through the pump. So this is what I was alluding to earlier. When you have a fully magnetically levitated system, there's really no wearing parts. This is a rare earth magnet and electromagnets kind of spinning this impeller in the middle of the screen, and that kind of accelerates the blood flow and puts it out to the body where we can improve blood flow around the body. So what we see, because of the improvement in the LVAD technology, is things like this. So in this particular trial, the Momentum 3 trial, we're looking at 6-month survival of close to 90%. And we'll talk about some other different trials, different companies and whatnot to understand this a bit further. But again, good survival. So looking at some further studies using this particular pump, HeartMate 3, you see in different studies, Momentum 3 done in the United States, and then in Europe, the CE Merck study, and then of course the registry in Europe, you can see very good, excellent survival at 6 months. And the interesting thing is that there are even trials that have gone on after this that have had even better survival, and we'll go through some of those today too. So basically, patients do get meaningful functional status improvements. We talked about walking more than a block and things like that. Functional capacity of patients is becoming more and more important to well, it's always been important to patients, but even to the FDA, where functional improvement of patients is really important. So 77% of patients actually improved NYHA class to 1 or 2. And this is a big deal. And actually, I think that this is important because it really occurs at 6 months. So pretty fast after you get your VAD that you're back towards really normal. And that really translates, nicely in a 6-minute walk distance. You can see the 6-minute walk increase, an 83% increase in distance. You can go from 164 meters to 300 meters plus after placing an LVAD in patients. And then I would, for those of in the audience that remember the CRT improvements in 6-minute walk, when you look at Companion or InSync for the CRTs, the increase in walks for those particular trials, that are seminal trials for a CRT and why we use them today, you're looking at about 30 meters, or a little over 30 meters as an increase from CRT, and you're looking at obviously an 83% increase here from 164 meters to 300 meters when you look at an LVAD. So patients really do feel better. They can walk longer, but also their quality of life score goes up as well. And here, this is KCCQ score from baseline at Momentum 3 enrollment into 6 months. And once again, they start feeling better pretty fast, actually. And I think that's important because I think these individuals, it's a big thing to ask somebody to go through an LVAD, and they really ought to feel better, and they really do. So we can look at, this in several different ways. Significant improvement we saw in functional class, 6-minute walk, quality of life, and that's in US and European randomized trials. And then, of course, this was borne out in further data in registry. For example, here in the Elevate European registry, it's still borne out that the 6-minute walk distance is increased and the quality of life is also increased as well. So again, going from a kind of highly structured a trial to then, kind of expanding that a bit towards usual care and out there in the universe, we saw that continued trend of improvement in 6-minute walk distance and quality of life. So that's important to know that it's preserved when it gets into broader use. So here we can kind of see what I was alluding to earlier. You look at baseline 6-minute walk tests, you can kind of see there that they're relatively low. And then at 3 months and 6 months, you've already seen a tremendous increase in 6-minute walk. So that's really, really good. I mean, I said 6 months, and now I'm showing you now that even at 3 months, there's quite a bit of an improvement. And also attainment of NYHA class 1 or class 2 at 3 months and 6 months is really traumatic. And then all these individuals are really pretty sick at baseline, and there was really no one class 1 or class 2 in the beginning of the trial. That's why there's no bar there essentially at baseline. And then KCCQ, again, looking at 3 and 6 months, you see a rapid rise at 3 months, and it's sustained through 6 and really beyond. So, it's a big deal to get an LVAD. What are the adverse events? I mean, I think that the thing is it's a big thing to ask patients to go through, and we go through this with patients as well. But device thrombosis really became extremely low with the HeartMate 3 as an example in this particular trial. Mucosal bleeding, such as GI bleeding and even epistaxis, is significant, again, about 15-16%. Stroke is still there, and it's no worse over time. But I think that's something that we have to recognize as potential for with this therapy, and I think that it's something that we need to work on as a discipline on that, and as engineers and physicians taking care of these individuals. Bleeding requiring surgery, you can see that there. Driveline infections, of course, are important. A lot of times this is something that we can treat, and we have ways of trying to prevent driveline infections, and that's gotten better over time with implant techniques and the like. But again, it's still there, and things in the future may be, in terms of fully implantable LVADs in the next few years in trials, may actually obviate that or really significantly decrease pump infection. So this is a particular publication we looked at here with HeartMate 3. We can see here on this Kaplan Meier panel on the left panel that we have a better primary endpoint profile for HeartMate 3 as compared to HeartMate 2. And this is reassuring because every successive generation of LVAD, we do see this phenomenon, and this is important to understand as potentially people that are going to refer patients for VADs, that this is a moving target in the correct direction. Again, looking at adverse events, pump thrombosis has become a lot better with the newer generation of LVADs. We do still have some problems with strokes. It's no worse with the successive generations, but we need to make some strides there. Bleeding, in terms of mucosal bleeding and GI bleeding specifically and epistaxis are definitely something that we need to try and improve. It's a bit better, but again, this is a target for us to improve upon. What is becoming more interesting, and what I wanted to bring today to the group, was less invasive implantation. This is important to look at. There are novel ways of implanting these devices that may not require traditional median sternotomy, and this is potentially a game changer because I think, again, less surgery and the same result may be something that patients really would favor, and referring physicians would favor as well. Patients just aren't created equal. We know this to be true, and you know, one may require a median sternotomy, but if somebody could have a lesser than median sternotomy strategy for an LVAD implantation, this might be helpful. So here what we see is a pictogram of how an incision would be made to put in an LVAD in a less invasive way, and you can see a lateral thoracotomy and a kind of a smaller sternotomy. Just the upper aspect of the sternum would be separated in order to put the outflow tract in. And I'll kind of just go through this quickly to give everyone an idea of how these things are put in this median sternotomy sparing way. A thoracotomy is opened for the aorta to allow for the outflow graft towards the ascending aorta to be placed. What we see here is kind of in the right pictogram, the pump is sort of in the left chest, and we have the moving over of the outflow graft across the sternum towards the right side of the sternum, and then up towards the ascending aorta underneath the sternum there. This is how it would look to the surgeon. This is the outflow graft as it plugs into the ascending aorta. And this is kind of a look at where the pump actually goes in. So you see the pericardium there. This is the LV apex. And this round structure that you see is actually a sewing ring that they place onto the myocardium. And what that allows them to do is to make a incision into this and place a coring tool, which essentially takes a plug, if you will, of myocardium out. And that allows for access to the left ventricle. And the pump you can see here being placed into there, and there is essentially a sewing cuff wrench, and it's physically attached to the apex of the heart. So you can understand how this might work. This is kind of a summary picture of that as well. And if you looked in a sort of an X-ray way on the right panel, you can see how the strategy would be with the pump underneath the left thoracotomy and the median sternotomy or the intercostal incision there as well, and then the drive line comes out at the abdomen there, lower on the right lower quadrant there. So why, would we do this? And I think this is important because many drivers occur between thoracotomy and median sternotomy. So to avoid reduced sternotomy is sometimes advantageous things for our surgeons. To preserve the sternum, I should say, for future procedures like a heart transplant might be a very reasonable thing to do. And there may be a little bit less blood loss in that situation. What is interesting is less right heart failure. I mean, and all that is fine. It works. It's mechanical. What we're really dependent upon is the right ventricle to work after all this. And, this may be something that the right ventricle is potentially spared in this strategy using a less invasive way of placing an LVAD. And you can see in the last 12 months in the US and the UK, thoracotomy-based VAD implants have really gone up nicely. And I think that may be because of better technique and descriptions of that, and some of the work done on both sides of the Atlantic to try and show that it is possible and can be done well. Barriers might be really that the thoracotomy might be technically more challenging than opening the chest and having good visualization. And I think it's more straightforward potentially for surgeons to do it in that way. But again, the negatives we talked about. patients may require other procedures to try and allow, that it may preclude them having it. If you need a valve done at the same time, you may have to do it median sternotomy way. Lack of data on this. People thought, well, maybe this could be done, but I don't have evidence that this is a good idea. And that is a perceived barrier to thoracotomy as well. Pump size is becoming less and less important as the pumps become smaller and in the pericardium or right near the heart, as I demonstrated earlier. So these are some barriers to thoracotomy, but I think some of these are actually going away and allowing our surgeons to really put these in a less invasive way. So for example, with the HVAD product, the lateral trial was done. This is the first trial to really examine VAD implant using thoracotomy rather than median sternotomy. And again, what we see is every successive trial that we really see in the VAD space, every time we do a new trial, the Kaplan-Meier survival gets better. And so we can see it out here to 24 months. 1 year survival at 86% is a very, very good number. And significantly shorter postoperative length of stay was seen in this trial as well. And less bleeding requiring reoperation was seen. Significant improvements in quality of life and functional capacity was still preserved in this novel technique of implantation, and the adverse events were comparable to previous studies. And so this really, really becomes excellent, and a real reason to potentially, even for those that can get it, to really move towards a thoracotomy-based program with a median sternotomy only if necessary strategy. We can kind of see this is a particular trial, and people from all over the United States and really the world were a part of this. The trial itself was very typical of a bridge to transplant population. What that means is that basically there was no exclusion for very sick individuals with cardiogenic shock. 80% of patients were in that Intermax 1 through 3, which is what we're seeing, unfortunately, around the United States. We hope to kind of bring that back a little bit towards Intermax 4 at least, to try and get patients seen a bit earlier and have better outcomes. But even with all this, we still saw an event-free survival rate that was quite excellent at 6 months and even at 2 years, like I showed in the previous graph from survival. And you can see that the folks that didn't have primary endpoint success, there was obviously some death. I think partly of that is because the patients were relatively sick. Some patients are not going to make it if they're Intermax 1, stroke, and then there are some exchanges and explanted devices as well that were very small in number. But again, to kind of stress this, I think this is really interesting. Secondary endpoint success was really important here because we're looking at a mean length of initial hospital stay of 18 days. That's a really good number. And the median of around 14 days. So again, this is really, really important. The continuous access protocol was about 26 days of length of stay. And if you look at lateral, which is done right on the heels of that, really was a lot less. And that's important as well as we move forward and trying to get these things paid for. Stroke, I think, basically was about the same. I think this is good. Are we where we need to be from a stroke perspective? No, but there was no adverse signal by putting the device in this way. Kaplan-Meier survival, I showed this to you earlier. 92% at 6 months, 87% at 2 years. I think that's really good. 89% at 1 year. This is pretty good, and this is in its day when this trial was presented, which is really not that long ago. This is some of the best survival we've seen in the LVAD space. Other secondary endpoints on this novel way of putting the VADs in, we saw KCCQ increase quite a bit. About 27 points baseline through 6 months. So again, by 6 months, people are feeling pretty good. The EQ5D is another way of looking at quality of life. Again, similar improvement over 6 months. And again, 6-minute walk assessment from 76 meters. That's pretty impaired. That's really sick. That's perhaps one of the sickest VAD populations that we've looked at so far, to over 224 meters at 6 months. And patients that really achieved NYHA class 1 or class 2 was about 66% at 6 months, and beyond that is potentially higher as well. Rehospitalization was important as well, and there was similar compared to other bridge to transplant trials. So, the fact is that LVAD therapy is really becoming more prevalent. I think it's becoming more available for patients now, and I think it's really going to become where the operative techniques combined with the pumps themselves improving so much is going to allow for a less invasive procedure for the patient with the tremendous support in their circulation. I think that we have some ways to go in terms of stroke and GI bleeding and infection, but there are things such as novel ways of managing the pumps to avoid stroke when we can, novel ways of looking at these pumps and anticoagulating them to potentially minimize GI bleeding, epistaxis, and the like. And, in the future, we're looking at fully implantable systems, which several VAD platforms are looking at now. And we should start seeing trials within about 2 to 3 years. And that is a huge satisfier for our patients as they can potentially shower more conventionally, take a swim, and avoid, which is a nuisance, but a driveline infection. I think the future is bright for LVAD therapy, and I think that this is going to be a fun next 5 years to see how this moves forward. Keep looking at this because I think it's going to be coming to your patients more often and sooner and with better results. Thank you for paying attention. I'd like to once again thank the organizers and Craig Walker for allowing me to be a part of the digital education series.